All right, we're going to now talk about 1-02, which is our initial assessment and exam. Now, most of this is relatively intuitive, things that are addressed in training, but I'll give you a general overview of some basic expectations. Obviously, you start when you arrive at a scene, just that general scene size up, and it's discussed a little more in depth in the Scene and Transport Safety Guideline, or Z-06. But generally, what you're trying to do is define the number of patients or casualties on a scene, as well as documenting their transfer of care to other providers or from other providers. Additionally, looking at your environmental hazards and the need for additional resources, and also documenting what other resources were on scene. Was fire on scene, hazmat, law enforcement, etc. And then finally, as far as crime scenes go, documenting any movement of the patient and any movement of any other objects that are in that crime scene to help our law enforcement colleagues. Next, we move on to just your general primary assessment, which is your general ABCs, especially documenting that kind of first impression, what that patient looks like, kind of sick, not sick, what does their alertness, their skin look like, obvious deformities, and then also documenting within that the reasoning, or how you got to the scene, who called 911, was it a bystander, was it a family member, was it the patient, was it law enforcement? Again, a lot of the legality associated with who's there and how you and other people potentially got there. The next thing is obviously with every patient is, if they're a pediatric patient, getting their color category. Now that can be based off a weight, as long as it is reasonably approximated, or preferably using some sort of length-based tape, be it Broslo tape, Pedia tape, to get their treatment category, and then ultimately documenting that category in the medical record. And then obviously at this point, you're going to, after your primary assessment is, doing and documenting your critical interventions. Once that's done, obviously we move on to secondary assessment, and there's different ways and different mnemonics that you can use to remember to get the appropriate points within the history, appropriate points within vital signs, and including pain assessment, as well as your secondary survey. Vital signs are one of the things that require a good amount of documentation. Minimally, we request that, unless the patient just absolutely refuses, that you get blood pressure, pulse rate, respiratory rate, mental status, and pain. The initial blood pressure measurement we would like for you to get manually, and also remember, if you've got either a regular pulse or regular breathing, should be monitored for the full minute to get an accurate rate. Mental status, for now, we're still using GCS. Although there's some newer evidence that's coming out that may hopefully get away from its use in the future. And then obviously, depending on the patient situation, you're going to use other potential vital sign and assessment markers. And we'll get into some of those with some of the other guidelines. One thing is documenting. Always, we request 2 measurements be documented: your initial or baseline vital signs, and then at least one prior to the transfer of care to another individual or another receiving facility. In addition to that, and this is both with the vitals as well as reassessments, at least a brief reassessment exam and repeat vitals should be taken and documented throughout the transport. So if there's a change in the patient condition, or if there's an intervention, the assessment and the vital signs should be documented after those changes. Specifically, if you've got a prolonged transport, we request at least every 15 minutes on stable patients, and more often for unstable patients. So again, that's a very brief overview. If there's questions or concerns, please feel free to get a hold of me, and I'll be happy to try and answer your questions as best I can. Thanks.